Hi, welcome back. Having gone through some of the basic concepts relating to tachyarrhythmias, let's go through some cases. So we have got a 66-year-old female who's admitted with a new sudden onset left-sided weakness, facial droop, and slurred speech. So this is suggestive of a stroke. CT scan does not show any bleed, so this is most likely an ischemic stroke. Her past medical history does confirm that she has got some risk factors for cerebrovascular accidents. ECG recorded is as following. So now ECG, we will go through our algorithm, but first of all, to check the rhythm, the best leads that we see are lead 2 or lead V1, and of course we need to get a rhythm strip so that we can better identify the rhythm. However, we can for this particular ECG we can go through the complexes in lead 2 and we can easily identify what the rhythm is. So of course this is a tachycardia. So I will see what the QRS complex is. The QRS complex is narrow, and now we need to see if the QRS complexes are regularly spaced or irregularly spaced. It's quite obvious that the QRS complexes are irregularly spaced, as the distance between two QRS complexes is not the same and it's not consistent. So this is an irregular narrow complex tachycardia and most likely causes atrial fibrillation. So this lady basically has had a ischemic stroke secondary to atrial fibrillation. Our second patient is a 55-year-old male with who's coming in with palpitations. ECG recorded is as follows. So again, this is the rhythm strip leads to so tachycardia, yes, QRS complex is broad, and now this is regular or irregular, and this is a regular broad complex tachycardia. In practice, we can actually map these the distance between these R and RR points, the RR intervals, and then we can compare some of these with some complexes down the line, and this can help us identify accurately if the rhythm is regular or not. So regular broad complex tachycardia, most common cause is a VT, and if we don't have any reason to doubt that this patient has got a previous bundle branch block or accessory pathway, we will treat this as VT. And as per the ALS algorithm, we give them amiodarone, but of course the best thing is to consult the cardiology colleagues in your hospital. Now, this is an interesting case. This is a 35-year-old male who's a young patient who's coming in with shortness of breath and fast palpitations that developed suddenly 1 hour prior to his presentation. He has not got any past medical history apart from some occasional episodes of palpitation. So the admission ECG when he is in tachycardia is this one. So now, as we can see, this tachycardia is number one broad because the QRS complexes are actually more than three small squares. So this is a broad complex tachycardia. Is this regular or irregular? As we can see, the QRS complexes are not regularly spaced, so this is an irregular broad complex tachycardia. So now we know the most common cause for a irregular arrhythmia is AF. But since this is broad, now we need to identify if this patient has got a previous bundle branch block that, or if he has got a previous accessory pathway which is causing his AF to appear broad. This is very important, as we have discussed extensively in the previous videos, because we don't want to give certain drugs to patients who have got broad complex irregular tachycardias who have got an accessory pathway, because this can cause their seemingly benign arrhythmias to could transform into ventricular tachycardias or ventricular fibrillation. This has been extensively discussed in part 2 of this series, so please refer to the part 2 of this tachyarrhythmia series to understand this concept. So this is the resting ECG for the same patient, and of course this has been done to identify if this patient has got an underlying bundle branch block morphology or if he's got any accessory pathway which is causing his AF to appear broad. So this ECG was recorded when he was not having symptoms and he was in sinus rhythm. As you can see, there's a P wave each P wave is followed by a QRS complex, and the rhythm is regular. So this is a normal sinus rhythm. Now let's focus on the QRS complexes. Actually, let's focus on the rhythm strip for this patient. So as you can see, the first most obvious thing is that this PR interval, this is very short. So the normal PR interval is 3 to 5 small squares. So this is less than 3 small squares, which means that the PR interval is short. And the other striking thing is a slightly broader QRS complex, and this upstroke, which is happening here. So this patient has basically got an accessory pathway, and he has got, as we explained in previous videos, Wolff Parkinson White syndrome. So now what happens there is in there he has got an accessory pathway which is connecting the atria and the ventricles, and which can allow the current to pass through. So what happens is, suppose if this patient develops an impulse and it travels down both these pathways. So since this accessory pathway lacks the impulse delaying properties of the AV node, it will conduct the impulse down, uh, and this will depolarize the ventricle muscle wall. So since the impulse is going down from the ventricular muscle wall, you will see this upstroke. This upstroke, slurred upstroke, is called the delta wave. And the reason for a short PR again is because of the lack of delaying properties of this accessory band. So you don't see the normal PR interval. So this patient has basically got Wolff Parkinson White syndrome. So this means he's got the accessory pathway, which is evident on the resting ECG uh, by the presence of a shortened PR interval, the slurred upstroke, which is the delta wave, and slightly broader QRS complex. So he's got the accessory pathway and he has got an arrhythmia. So broad complex arrhythmias in Wolff Parkinson White patients are a bit complicated to manage, and you cannot manage them as you would do for the same arrhythmia in when the complexes are narrow. The reasons are again discussed in the second part of this series. So that's why this patient has got AF. So for example, normally if someone had AF and their complexes were narrow, you the options that you can use are either beta blockers or calcium channel blockers, for example, if the beta blockers are contraindicated. However, in patients with Wolff Parkinson White syndrome who have got AF with broad complexes, you can never give them a calcium channel blocker which will block the AV node, or you cannot give them any other AV nodal blocking agents like adenosine or diltiazem, etc., or even digoxin, because this would precipitate the impulses going down from the accessory pathway and leading to VTVF, as explained in detail in video number 2. So different hospitals have different guidelines to manage this sort of a situation, but as a junior doctor, the most appropriate thing to do is call the cardiology team. That's it. Because most commonly the drugs that are used are amiodarone or flecainide, or actually some of them would prefer just doing electrical cardioversion instead. But again, this has to come from a cardiologist, so get in touch with your cardiologist sooner rather than later. Now let's just briefly go through some of these ECGs as well as per our algorithm and try to see if we can identify the rhythm. So this patient has got a tachycardia, and let's look at the rhythm strip. So this patient has got a narrow complex tachycardia. So these tachycardia QS complexes are narrow and they are regular. Now the P waves are present or not. So if you look closely, the P waves are present. So each P wave is followed by a QRS complex, then a T wave, and then a P wave. Of course, this P wave is merged into this T wave, and this is most likely a sinus tachycardia. So of course, for sinus tachycardia, you treat the underlying cause. You don't give them rate limiting medications generally. So this patient, again, let's see, focus on the rhythm strip. So QRS complex is narrow, less than 3 small squares, and this is regular as well. Are the p waves present? No. So there are no p waves present. These waves that we are seeing are of course not p waves. So p waves are absent. Are the flutter waves present? Yes. So these are what flutter waves look like, the sawtooth appearance of the flutter waves. So they are visible. So this is an atrial flutter. Now if you see, this is actually an atrial flutter with 4 to 1 block. So for every 4 impulses, one is allowed to go through, and this is what you see on an ECG. Now again, this is another ECG. Let's focus on the rhythm strip. So tachycardia, QRS complex is narrow, and this is regular. Are the P waves present? No, we cannot see the P waves. So if the P waves are absent, we need to see, are the flutter waves present? No, they are absent. So now if the flutter waves are absent, we need to do vagal maneuvers, and if they fail, we need to give them adenosine to see what the rhythm is. Vagal maneuvers and adenosine would block the AV node. So if this happens, and if the sinus rhythm is restored, and this is AVRT or AVNRT, because blocking the AV node in this instance would block one of the components of the re-entry circuit pathway, and this would lead to termination of AVRT or AVNRT, and the sinus rhythm would be restored. However, if this is actually flutter with 2 to 1 block, then what we will see is blocking the AV node will make the flutter waves appear, and this will unmask the flutter waves, and you will see the flutter waves as you saw in the previous ECG, these ones. So these ones would be unmasked if this is actually a atrial flutter coming as a narrow complex regular tachycardia. So if there are any questions or any queries, please let me know in the comments below, or you can let us know on the Facebook group. These are the references that have been used in these videos. Most important is the Rhesus UK tachyarrhythmia algorithm and the associated guidelines. There's an excellent website which is the Life in the Fast Lane, which is it's an awesome website for lots of things, but the ECG sections are really good. If you want to know more about basic interpretation of ECG, then this is a good starting point. ECG Made Easy series by Dr. Hampton. Thank you very much for listening to these videos, and hope you have a good day. Again, if there are any questions, they're most welcome.